We're now going to continue on our theme of cancer, and our next speaker is Dr. Scarlett Lin Gomez from the University of California, San Francisco. Dr. Gomez received her M.P.H. in Epidemiology from the University of Michigan also, and then her Ph.D. in Epidemiology from Stanford University in 2002. She's had an extremely productive research career with over 250 peer-reviewed manuscripts thus far, and also has an extremely productive current research portfolio. I counted that she's principal investigator of currently 5 R01s, all of them being cancer related. She's also co-leader of the Cancer Control Program for the Helen Diller Family Comprehensive Cancer Center at UCSF and director of the Greater Bay Area Cancer Registry. She's contributed surveillance data of cancer incidence and outcomes for distinct Asian American, Native Hawaiian, Pacific Islander, and Hispanic ethnic groups, as well as cancer patterns by nativity status and neighborhood characteristics. Today, she will be presenting on integrative data approaches for addressing multi-level contributors to cancer health disparities. So Dr. Gomez, you can go ahead and share your screen if you're ready.
All right. Are you guys able to see that and hear me okay?
Yeah, we can hear you great. If you could just go into slideshow mode.
Okay, how's that?
Looks great, thank you.
Okay. So I thank you so much to the organizers for having me here today. And, you know, every time I listen to Dr. Nguyen talk, I just, even though here it's 7 o'clock in the morning and I've been listening to him since 6 o'clock in the morning here, it's just, as one of the commenters said, really mind blown every time. It's just so inspiring. And I hope to be able to follow upon some of the themes that Dr. Nguyen presented with regards to sharing one particular research program that my group is focusing on, and using that as an applied illustration of how we're using data integration as an approach to better understand a particular health disparity. This here, the schematic, which comes from the Benton Franklin Health District, really is the driving force and the motivation behind the work that my lab does. What this graphic shows is, as Dr. Nguyen so nicely has been talking about, a continuum of influences on health outcomes, and focusing really particularly on the upstream factors here, particularly the social inequities and institutional inequities as a result of the historical and current institutions that exist within our society. These impact upon the living conditions, our social and the built and physical environments, which subsequently impact upon the behaviors and health outcomes. The upstream and downstream directionality of this graphic is particularly important. And I want to really highlight this because as we know, the vast majority of research, biomedical research, focuses on these downstream factors. But as you see from the background pictorial here, and again, as Dr. Nguyen illustrated, we can't begin to fully impact upon these downstream factors until we also start to address these upstream factors, because the influences flow from the upstream to the downstream. And this is kind of the beauty of doing these presentations from home, as Dr. Nguyen was answering the question about actionable small area level analyses. I wanted to share quickly one example in which we've been able to use our data. This is now wearing my hat as the director of our regional cancer registry, to be able to generate and put out there information to stakeholders in the general public and decision makers, data that are meaningful and actionable. So this is actually, this is a little bit of an aside from the main topic of my presentation. This is our mapping portal that our registry produced in collaboration with NCI and WestStats, called CaliforniaHealthMaps.org. Following this project, NCI has actually taken this format and partnered with additional state cancer SEER cancer registries to generate a similar kind of mapping portal. One particular aspect I wanted to illustrate is that we have been hearing because of our role in operating a cancer registry, been hearing from stakeholders, particularly community members, that the traditional way in which we examine, the traditional geography by which we examine cancer incidence, which is at the county level, is the smallest areal level, is really not meaningful for being able to influence upon actionable reductions in policies for reducing cancer. This was the primary motivation in our partnership with NCI and WestStat, was to see if we could, if it's feasible to report cancer incidence rates at a sub-county level. So this is what these zones are. Zones are aggregations of census tracts based on attribute similarity. For California, we have 58 counties, and we were able to, through this project, develop 580 zones. And so you can see here the geography of some of the zones in some of our really urban areas like the Bay Area and LA. There are very, the zones are much smaller in geography than the counties. But what I wanted to particularly point out here is that in addition to the zones, we provide with this pull down menu, several additional area types that users of this website are able to use to pull up, to query cancer incidence rates. And this was also following on feedback we heard from stakeholders that yes, sub-county area levels are great. MSSAs, which is a particular geographic unit, also sub-county within California, that's great. Census designated places, great. But what we really want to would be really actionable, would be able to, is to be able to produce data that our Congress people, our legislators can really use. And so we have also within this mapping tool provided the ability to query cancer incidence rates by additional political districts, voting districts. So I will move on, thinking about that schematic, the upstream, downstream schematic, and talk a bit about now a project that we're using in which we're applying that concept to a multi-level approach for addressing cancer health disparities. This is probably, hopefully well known to many of you. This is the Salsa Society model that came about from the Centers for Population Health and Health Disparities, a program of multiple projects within the that was funded by the NIH. This graphic is adapted from a publication in American Journal of Public Health in 2008 from Dick Warnicki. And what it illustrates is the interaction of factors from cells, biological factors, to society, upstream to fundamental causes. And the idea that we must begin to study the interactions among these factors in order to better understand underlying causes to cancer health disparities. So I'm going to talk about how we've applied that framework and this model to looking at lung cancer in never smoking Asian American, Native Hawaiian, and Pacific Islander females. This is perhaps a disparity that's less well known, but in fact, as you'll see from some of the data that I am going to present, definitely a persistent and striking disparity. Why lung cancer among Asian American females? As you could see here, these are mortality rates and the proportion, these are the rank based on the age-adjusted mortality rate and the percent of all cancer deaths for different Asian American ethnic groups. The top panel are the data for males and the bottom panel are the data for females. You can see here that I've highlighted among females for all of these 6 largest Asian American ethnic groups that lung cancer ranks in the top 1, 2, or 3rd most common contributor, largest contributor to cancer, overall cancer mortality of all cancer sites. Why is this striking? This is striking because among Asian American females, very low percentages of them, in fact, smoke or active smokers. When we look at data from the Behavioral Risk Factor Survey or the National Health Interview Survey, for example, generally fewer than 5% of Asian American females are smokers, yet we see here that lung cancer is a major contributor to cancer mortality in these populations. We also know that this population that we call Asian American, Native Hawaiian Pacific Islander, or sometimes we see them referred to as API, Asian Pacific Islander, is an incredibly diverse population. They represent people from 30 different countries and speaking more than 100 different languages. And we also know from our descriptive cancer surveillance data that lung cancer incidence varies widely across these groups. What's particularly notable is that in select case series, we have noted that more than 50% of lung cancer cases in Asian American, Native Hawaiian, Pacific Islander females are among never smokers. This is incredibly high, and when we contrast this to the number of 15% of lung cancer among never smokers when we look among all US females. Yet until now, until our work here that I'm going to be sharing with you, we've had no sufficiently large data source to be able to document what the actual incidence rates are by detailed race, ethnicity, and smoking status. And this is because smoking information and cancer registry data have only recently begun to be collected, and we see lots of missing data. So it's really currently not usable information as of yet. And of course, because we also have no population estimates by smoking status to be able to estimate incidence rates. That was the motivation for our project. We put together a team comprising of my colleagues at UCSF, Stanford, Sutter Health Northern California, Kaiser Permanente Hawaii, and through partnership with 2 state cancer registries. This was funded by an R01 with myself and my colleague, Dr. Iona Chain, as the PIs. The objective of this study was to firstly assemble a multi-level integrated data set, then to conduct incidence analyses by smoking status and by groups defined by detailed race and ethnicity. Apologize for my dogs. And then focusing in particular on Asian American, Native Hawaiian, Pacific Islander females to compare the distributions of sociodemographic and tumor characteristics and to conduct risk analyses. We published in CEBP last year the approach to this integrative data analysis. And briefly, our methods were to compile a cohorts, a longitudinal cohorts. Cohort comprises all individuals, including all sexes and all race ethnicities, who had had an in-person visit at 2 healthcare systems, Sutter Health Northern California or Kaiser Permanente in Hawaii, as recorded in their EHRs. We chose these 2 particular healthcare systems for their high representation of Asian American, Native Hawaiian, Pacific Islander groups. Sutter Northern California covers 1/3 of the Northern California population. Kaiser Hawaii obviously is a much smaller healthcare system, but is very robust due to it being in Hawaii, robust with regards to its representation of Asian American, Native Hawaiian, Pacific Islanders. We also were interested in partnering with healthcare systems that had data that could check 2 boxes with regards to the data that they had in their EHRs. One is that they have complete and detailed information on race, ethnicity. And at the time that we did this study, that one box cannot be checked by the vast majority of the healthcare systems that we approached to partner with. The second criteria, the second box that the healthcare systems had to be able to check was to have complete information on smoking status. And again, this is something that even today is not being consistently and completely reported across all healthcare systems. The inclusion criteria are that the cohort members must be 18 years of age at the baseline visit, have a California or Hawaii address at the time of the baseline visits. This facilitates follow-up for lung cancer diagnosis by linking to the relevant statewide cancer registries. To enable collection of smoking status, individuals must have had collection of social history at some point during the study period to be able to be included in the cohorts. The exclusion criteria with that was if they had a history of prior lung cancer diagnosis, either recorded within their medical record or registry case record. This resulted in a cohort that included over 2.2 million individuals, 1.87 from Sutter Health and 340,000 from Kaiser Hawaii. The overall cohort included 1.275 million females and a little over 1 million males. And for all cohort members, we extracted data from the EHRs on sex, race, ethnicity, smoking status, and preferred language and whether a translator was requested. And just a little bit of further detail on how we looked at smoking status. This was actually probably a several month-long process because this was a key variable of interest in our analyses. Smoking status was specified we developed a simple algorithm that used smoking status values from 2 different time points. The first smoking status collected after the baseline visits, and the last smoking status collected during the course of our study end dates or the date of their lung cancer diagnosis. We ended up classifying smoking status as ever, comprising former or never smokers, and never smokers, comprising those with values only for never or for passive smoking. Then among Asian American females who've never smoked, and this was a little under 200,000 cohort members, we extracted additional data elements, specifically known imputative risk factors from their EHRs. We then conducted a linkage to 2 statewide cancer registries, California and Hawaii, linking based on names, dates of birth, and social security numbers. At the time we did this analysis, we were able to link through follow-up data through 2013. And then from the cancer registry data, we included lung cancer cases that were microscopically confirmed and were carcinomas. We ended up identifying over 7,000 lung cancer cases. And we extracted from the cancer registry select information, including dates of diagnosis, tumor stage, and histology. We then also geocoded all of the data from the cohorts. Over 2 million individuals were able to have their addresses geocoded. And we did geocode it to a block group level, so that gave us the most flexibility in terms of being able to integrate in geospatial data. For this study, we were specifically interested in neighborhood factors, including neighborhood socioeconomic status, ethnic composition, and traffic density, as well as regional air pollution. And this here, we were able to ascertain this only for the Northern California Sutter sites. So specifically, we looked at a measure of particulate matter 2.5, PM 2.5. This very detailed schematic here, which don't worry, I'm not going to be walking through in detail, but the idea really is to show you how much granular information we were able to glean from these 2 healthcare systems and the degree of critical thinking that our group collectively went through to think about how to code race ethnicity within this study. Our approach at a very high level was to prioritize coding of Asian American, Native Hawaiian, Pacific Islander groups. Oh, I should mention that in both healthcare systems, the patients were allowed to identify with multiple race ethnicities. So we really took a lot of time. This was probably just a 6-month process alone among our large group just to decide how to code race ethnicity, including how do we code the multiple race groups. We also were really interested in prioritizing smaller populations, as well as being able to distinguish between single and multiple races and ethnicities. This graphic shows the representation of the Asian American, Native Hawaiian, Pacific Islander populations within our cohorts. The integrated approach and selection of the 2 particular healthcare systems with high representation of these populations, as you can see, allows for us to be able to study these groups, to have sufficient numbers of these ethnic groups to allow for subgroup analyses. And so as you can see, while 5.5% or 5.6% of the overall US population is Asian American, nearly 16% of our cohorts is Asian American. And while 0.1% of the US population is Native Hawaiian, 2% of our cohort is Native Hawaiian. Okay, so results. This graphic shows the distribution of smoking status among female lung cancer cases from our cohort. So there be that a little under 4,000 cases by detailed Asian American, Native Hawaiian, Pacific Islander race ethnicity. So let's start first with looking at the proportion of never smokers, or LCINS. So that's represented here by the teal part of the stacked bar graph. In this cohort, we see that among the females diagnosed with lung cancer, 21% of the non-Hispanic whites were never smokers, 14% among Black or African-American women, and 38% among Hispanics. For Native Hawaiian Pacific Islanders, 15% were never smokers. And for Asian Americans combined, 50% were never smokers. But we also note tremendous heterogeneity in never smoker status across the AA and HPI groups, ranging from 14 and 20% among Native Hawaiians and other Pacific Islanders to 79% among Chinese females. I just want to pause here. The first time we ever saw these results, the first time that these results have ever really been illuminated among these Asian American ethnic group populations are in these results here. The striking number among Chinese American females. So this is to say among females with lung cancer, these are people diagnosed with lung cancer, 80% of Chinese have never smoked. This was recently published just late last fall in the journal JNCI. So we also looked at incidence rates of lung cancer because we designed this EHR integrated cohort as a longitudinal study. We were able to calculate incidence rates. And what you can see here is that compared to the incidence rate among non-Hispanic white female never smokers, the age-adjusted incidence rate was 10.1. Nearly all Asian American, Native Hawaiian, Pacific Islander groups had incidence rates that were 1.5 to 2 times higher compared to the non-Hispanic white group. The striking exception was among Japanese American women, although you could see that the confidence intervals, even with our large data set, confidence intervals were still somewhat wide. And so this observation among Japanese American women, we actually see for several other cancer sites where their patterns tend to look more similar to that among non-Hispanic whites. We see this for breast cancer as well, for example. And this likely is due to, in part, to the fact that Japanese Americans as a group, they're one of the first groups that have immigrated here to the US. And we do tend to see higher proportions of later generations of Japanese Americans in the US. We are wrapping up our analysis on this R01 by looking by our focus. This is the AIM2 that focuses specifically on Asian American, Native Hawaiian, Pacific Islander, female never smokers, using data from the EHR on smoking, previous lung diseases, infectious diseases, and reproductive body size. We're analyzing their associations and calculating attributable risks associated with lung cancer risk. And through the geocoding and linking in of geospatial data, focusing in particular on air pollution and neighborhood social environments, looking at their associations as well. And my colleague, Mindy Darawan, has an administrative supplement in which she's merging in additional neighborhood social, built, and physical environmental data elements and applying a random forest machine learning approach to an exposomic approach to analyze, identify additional neighborhood factors associated with lung cancer risk. We've been able to apply this model, this approach to a second study looking at liver cancer disparities. This study is looking at disparities in HCC, hepatocellular carcinoma incidence, as well as surveillance of high-risk individuals. In addition to the 2 healthcare systems that we included in the lung cancer study, we in this study have been able to add an additional healthcare system, the San Francisco Health Network, which comprises the public hospitals and safety net hospitals within the county and city of San Francisco. In this study, we're looking at neighborhood level factors, including neighborhood SCS, ethnic enclaves, as well as patient and provider level factors derived from the EHRs. So some lessons learned. There are many, many lessons learned from this experience. Here are just sort of some running thoughts that our group have put together. Some considerations when using this data integration approach. The approach obviously is highly efficient. You saw the numbers that we were able to get compared to de novo development of inactive cancer cohorts. However, we also learned that data integration is very, very time consuming and requires a lot of efforts in ways that may not be obvious, certainly to us in the planning phase. The approach, especially if you're using data across multiple institutions, involves extensive, and I cannot underscore this enough, extensive data sharing and data use agreements, BAAs, et cetera, including mutually agreed upon data transfer protocols. In addition, it's vital to specify data extraction with knowledge of data structures at each site and to spend the time needed on procedures that will harmonize the data across the sites, creating merged variable categories while trying to preserve as much granularity as possible. We took a lot of work care to describe the representativeness of our cohort, recognizing that these healthcare systems, although they do represent a fairly substantial chunk of the underlying population, is certainly not population-based. So we recognize that this effort was needed to aid the interpretation of the generalizability of our results. Further, extensive and informed data cleaning and attention to missingness and bias is a must. So we really spent a lot of time, probably a good year, just doing different sensitivity analyses to understand. We know that these data were not collected for the purposes for which we're using them for. So we really wanted to understand and rule out any sources of bias in our results. We know that communication and documentation were key. The project had data stewards at each of the healthcare systems. We used detailed variable dictionaries and provided data sites with coding dictionaries. Even with that effort though, data cleaning and preparation typically warranted correcting coding dictionaries and repeated data extraction. So that's something now going in that we definitely need to factor in. And with that, I want to thank you for your time, and hopefully we have time for a few questions if there are any.
Thank you so much, Dr. Gomez. And let's see, we're a bit behind, but if anyone has a question, please feel free to unmute yourself and ask it.
Dr. Gomez, thank you for your presentation. One of the things that's really interesting to me is when you say the Chinese woman has a higher sort of lung cancer rate, though they are actually less likely to be a smoker. What is your hypothesis on explaining this? Have you considered this sort of a secondary smoking or kitchen?
Yeah, thank you for that question. We unfortunately did not have good secondhand smoke data within the EHR data to be able to look at that factor specifically. Unfortunately, the way that healthcare systems code smoking status is really one variable that has a code for secondhand smoke. So it's not coded mutually exclusively. And the proportion that had a secondhand smoke exposure coded within our cohorts was just really negligibly small. So we estimate there might be some under ascertainment of secondhand smoke within these populations. We are actually doing, I forgot to mention that following on the results from what I just presented, we received funding to do actually a population-based case control study in which we're collecting de novo data to be able to identify what some of these risk factors are. So exactly answering the question that you're asking. We don't know exactly what's contributing to the high burden of lung cancer among Asian American female never smokers because there's never been a study done here in the US actually. The case control study that we're doing is the first effort to really start to disentangle this. However, there have been many studies done in Asia. And those studies have identified risk factors, including exposure to secondhand smoke, air pollution, and factors like exposure to cooking oil fumes, using coal as a heating element indoors, especially in the presence of poor ventilation and previous lung diseases. But we also note that the prevalence of these particular exposures are much, much higher in Asia than they are here in the US. So we don't know the extent to which these particular factors may be relevant here in the US. And I want to note that in our case control study, we're really focusing on some of these exposures as a social justice issue, as a health equity issue, to the extent that we know there are particular occupations and occupational exposures that may be more common among Asian American populations here in the US, as well as neighborhood level exposures.
Yeah, thank you so much. And one other thing I'm just curious about, do you have data on the immigration status data, like people who have early exposures versus later on the air pollution side?
Right, yeah, that's another great question. It's the healthcare systems did not collect that information, but that was why we extracted information on language and translator use, which is really collected for clinical care purposes, but that was really the extent to which we were sort of able to get at that factor. But we're certainly collecting very detailed immigration history and residential history data in our current case control study. And of course, you know, I think it's important to know for any one of us who are doing small area level analysis is the residential history, and especially here, the outcome we're looking at, lung cancer incidence, lung cancer risk potentially has a very long latency period. And the way that we're looking at neighborhood level and physical environmental exposures is, you know, just that one snapshot in time. So there's a lot of assumptions that go into that exposure, the way that we're measuring it.
Thank you.
Hey, thank you very much. And thank you, Dr. Gomez, for being willing to join us so early in the morning in your time. So at this point, we have a break planned. I think we'll shorten that to just 5 minutes and we'll start back at 10:40. If people online want to continue, you know, ask a couple more questions, that's fine. I wanted to give a break to everyone in person at least.
Whenever you are.
Unmuted.
Unmute.